So this technique is called interdigitating technique, and so this was pretty much developed by Dr. Van Nastel. Hopefully he's here with us on the call. So essentially I've learned everything from him, so it's not really my technique, but I'm happy to share. Also we're excited to show you two quite different techniques. Both are quite effective to treat this arch anomaly. Can you see my screen?
Yes.
Okay, so yeah, I was just gonna start the video, and then we'll just kind of stop when I have to explain a bit more. First of all, our 3D final PAM spend hours and hours recording and then editing this video, so we're so grateful. It's a great video clips. So as I said, it's an interdigitating technique, so mainly developed by Dr. Van Nastel when he was in Toronto. So this is typical. So the model you have is typical hypoplastic left heart syndrome with aortic atresia, with mitral atresia, with quite diminutive ascending aorta, and large PDA, and hypoplastic aortic arch. And so this is the view from the left side. So you have a huge duct and hypoplastic aortic arch, and then the isthmus area. Obviously, those are the ductal tissue. You can see how close this area of distal aortic arch to left bronchus and then the left promyarty. So those are the problem of some of the patients who have this type of reconstruction. So interdigitating. So this is the kind of end result of an interdigitating technique. So we're just going to go through the steps. But the essence, I think, difference compared to other techniques is to have two incisions into the descending aorta with a hope that that will minimize aortic artery obstruction at the distal anastomosis level. So this is a proximal part, and so distal end will show you in the steps. Okay, so first part, obviously, to deal with a large PDA. So there's many ways to go on bypass. My personal take is that if ascending aorta is big enough, I do want to cannulate ascending aorta. And if ascending aorta is really small, like this patient, then I may put a graft in innominate artery. Or in some cases, I choose just to cannulate the distal PDA with a snare around the branch promyartis, and then a single right atrial cannulation. And so here, the first we ligate the PDA just distal to the LPA. My aim is to divide the PDA. Also, it's quite difficult in some cases because of the exposure. And just to demonstrating a suture ligation of the distal PDA. So in reality, this is not that easy to divide the PDA like this. Once we so we cool down to 20 degrees, so I typically cool down about 20 minutes, and circuit arrest. So here I'm grabbing the origin of the right pulmonary artery, and then the cut just underneath. So you want to have as much main PA as possible, but also you don't want to cut into the origin of the right PA. So you can see the LPA origin is more remote to the posterior commissure of the pulmonary valve compared to the right PA. So the main things to look at is just cut between the origin of right pulmonary artery and top of the commissure of the pulmonary valve. And then go ahead and transect the isthmus. So this is going to be used as a first part of the interdigitating anastomosis. We're just cutting kind of oblique. And go ahead and cut it out, all the ductal tissue. And so this is, so we're under pure circuit arrest. And then, so this is the opportunity to, so once we cut this, obviously we dissect the descending aorta all the way down to the spine so that you have more mobility. And then also there's no tension. And so cutting back, so when you start the cutting, this is pretty much the direct lesser curvature of the aortic arch. And then when it's come to ascending aorta, go slightly anterior to make the DKS, the anastomosis easier, but you don't want to spiral too much. That will kink the ascending aorta. And then once you finish the incision to the ascending aorta, then you're going to look where you want to cut the pulmonary root. So what we're looking at here is that I'm grabbing the right posterior commissure of the pulmonary valve, and we're going to have to decide whether you make an incision anterior to the commissure or posterior to the commissure, just depending on the relationship between the pulmonary valve and ascending aorta. So this time we decided to cut anterior. So this is kind of recent modification I started doing. So sometimes when you make just a slit, this pulmonary valve, pulmonary root, particularly when the root kind of a wall thickness is really thick, try to collapse onto the small ascending aorta. So the reason that I'm just cutting out a little bit of wall so that it does not collapse onto the ascending aorta. So it's kind of small V-shaped incision, and I started sewing DKS anastomosis from the bottom. So typically here I use either 7/0 with a small needle, or in a small patient use 8/0, and then tie completely so that we don't have lots of suture hanging to deal with. Okay, so this is the kind of end result of DKS anastomosis. So make sure those areas are not compressed and looks unobstructed. So if you have a choice, you don't want to go too proximal or too close to the left coronary artery, which is not too far from this incision. Move on to the distal arch reconstruction. So this is the first part of interdigitating anastomosis between the native distal aortic arch and descending aorta. So this part of the anastomosis is a frequent area of significant bleeding. So I'll be very careful and not advancing too much. The part of the problem is that some of the tissue, particularly around the origin of the subclavian artery, may have a ductal tissue. I think that's part of the problem why we have bleeding issues sometimes. So this is the first part of the interdigitating. So this is the descending aorta, and distal arch is connected. And the second part is the counter incision into sort of an inferior lateral aspect, anterior lateral aspect. So so it's almost 180 from this posterior incision, but I cut a little bit lateral to make the anastomosis a little easier. So that's the incision there. And cut it out the wedge, so that it will be kind of nice wedge. And let's go back, sorry. So I just want to explain how much we're going to cut into it is about the diameter that you want to enlarge in this area of anastomosis. And part of decision is influenced by the size of the descending aorta. Sometimes the descending aorta is smaller than you think, but typically they're good size. And then also the tension on the descending aorta. So the part shape. So this is, I'm just drawing from the top of the patch, but when we use the pulmonary homograft, we actually do this design from inside of the pulmonary homograft and then flip it. So it's a little different, but this one we're just sewing, designing from the outside of the patch. So I make it a greater curvature pretty much straight, like almost like a straight all the way. This area I just make it a little more bulging, so that's gonna go around the inferior aspect of the descending aorta. And then so this is this is quite useful technique, but so one thing we want to keep in mind is that you don't want to make this arch too big. That will compress the bronchus and LPA. So what I'm doing is, so this is the corner. It's the most inferior part of the reconstruction to the greater curvature. So this is what we wanted. And then obviously you have to account for the DKS, which is also the big structure. But in my limited experience, this dimension won't be that different from this dimension. So I think this is the biggest dimension of the arch patch. So that's how I design it. Sorry, I missed the, yeah. So when I measure this, go back, and so this is about the dimension we wanted. So that's how I make the widest part of the patch. But you can see I leave plenty of room to adjust as we go. So starting, so this is the lateral view, and I'm just sewing I started from sort of 3-4 stitches from the actual toe stitch, and then go around the toe. And then I keep sewing until this the suture of the first interdigitating part, posterior part. So this is kind of optional. If you have too much edge, we just cut it out. And then I didn't show it in this video, but I usually tie this suture together and then start with the new stitches to reinforce those area that 3 tissues come together. Here, started the inferior part. So you can see this marking is the widest part. So that's gonna go around it and then fill the gap at the inferior end of the first interdigitating part. So we'll show you in a minute. And so this is a very long suture line. And the one thing I learned from Dr. Van Nastel is that you're gonna have to decide whether it's more efficient to sew from outside, like we're doing here, and then I just switched from sewing from inside. Yeah, so it's really depending on the exposure, but you have both options. So particularly in the patch augmentation in a long suture line, you kind of have to keep thinking about what's the most efficient way. So now it's so this is the most kind of inferior part, and then that's the widest area of the patch. Now, so you can see this patch goes all the way around, sort of 2/3 of the circumference of the distal arch. Then you can augment, so you can trim the patch according to the curvature of the lesser curvature here. And then, so once we get, so this is a trimming of the patch from the most inferior part of the distal arch to the transition between the aortic arch and an ascending aorta. Then once you come to that, we have next trimming, which is, just follow this, the edge of the ascending aorta. And then keep sewing until you hit the DKS anastomosis. And here, so when you get to this point, we are sort of 2/3 of the suture lines are done. And then here, so this is optional, but here is a last opportunity to trim the greater curvature if you think this patch is too bulky. And you don't want to do too much. Then if you cut too much, then that will compress this area and then end up having narrowing proximal arch. But I always look at it to see if I have opportunity to make the patch smaller so that it's less bulky. So that's how I trim it. And then that's the timing. And then next incision is quite important. And then for me, it's still tricky. So this is almost cutting back towards the patch, towards lateral sort of posterior aspect. That's corresponding to the this curvature or this line of the posterior aspect of the pulmonary root. This is important to cut back, otherwise it's going to be too redundant, and then have a redundant infolding of the patch. So you're kind of sewing back there so that you have a straight so by this point, you almost see whether you have a good reconstruction, a bad reconstruction. If you have a really bad reconstruction, you can see the infolding along the way, then you may want to revise it at that point. But this one looks very good. And then last piece is this kind of what Glenn calls tongue, anterior tongue. So by this point, your patch shape is pretty much fixed. Only tweak is to make this width of the anterior tongue. So this one is pretty good width, so we just keep sewing until the top of the DKS. And so this one also is important. So if you make it too long, it's gonna kink, and then it's make it too short, it will compress the roof so that you have a little obstruction just beyond the DKS here. So I usually wait this trimming until very end, if I get until I hit this corner. And then this marking is the middle of this patch, and then this is the middle of pulmonary root, so that I don't distort the roots. So and so before I finish, I usually make a RV incision for the sano through this the pulmonary valve. I just use a right angle instrument, just like we do for the right ventriculotomy for conduit, any conduit, and finish up. Okay, I think that's about it. Can't see the whole one. I'm not sure Glenn's on the line or not. Do you have any questions or comment about interdigitating technique?
Everyone stunned into silence. Sorry. Perfect. Beautiful demonstration. It is nice, I think, in a way that it really gives you a large, volume and size to the arch distally. But it's the trick is judging that patch. I think the way you show it, where you kind of trim it and shape it as you go, is a way to do it. Yeah.
Yeah, I think it's this one technique. It's probably almost impossible to pre-made the patch shape. I just make the first part of the patch, and then trim as we go. And but once you get once you know where you to trim the patch, and that shouldn't be too complicated, hopefully.
Dr. Honjo, can I just ask, for your greater curvature side of your patch, initially you keep it straight. When do you make your first incision on that part? At what step? At what stage do you think about trimming that? And do you keep it straight, or do you like curve it with the curvature of the greater curvature of the aortic arch?
So for whatever reason, it's we don't need to trim that much. It's really a straight all the way from the descending aorta to the ascending aorta, which is kind of interesting. So either no trimming on that part whatsoever, or when I get the lesser curvature suture line to the DKS, then I have rough idea of how big this bulging will be, and then if it's too big, I'll just trim a little bit. But as I said, the one warning is that if you trim too much, then you don't have enough ribs on the anterior tongue to accommodate all the DKS or pulmonary roots, so I have to be careful. But that's when, before I cut back to the, so when I reached DKS, before cutting back to the patch for the back for the DKS, I trim it if needed.
Okay, yeah, because when I've tried it in the past, that's the problem I've made. I've overcompensated and trimmed too much, and then it flattens the DKS at the end.
Yeah,